Morning, everybody. Good morning, everybody. My name is Charlene Webb, the Health Director for Kitsim-Kalem. I'd like to welcome you to today's wellness webinar hosted by First Nations Health Directors Association. I'd like to acknowledge the Tsimshian territory to which I am sitting, and for all of us collected here today, respecting the traditional areas to which you are joining us from. I'm joining from the unceded territory of Kitsim-Kalem. We're located 3 kilometers outside of Terrace. My name is Charlene Webb. I'm the Health Director for Kitsim-Kalem. I became a FNHDA band member and, sorry, look at that, see? FNHDA member in September 2013. And I've served on the FNHDA board since January of 2020 as the Northwest representative for the Northern region. I'd like to take this time to welcome the presenters. Warren, forgive me if I pronounce your name wrong. That's not my intent to disrespect that. Today we welcome Warren Claremont, Director of Indigenous Cancer Control, BCCS, Joanne Munson. Okay, I'm getting there. Program Manager of BC Cancer Lung Screening Program. That's exciting. Victoria Steves, Quit Coach Partnership and Promotion, BC, and Kim Masur, again, correct me if I'm wrong, Talk Tobacco Partnership and Promotion. I'm very excited to learn more about the 2 new programs in BC to support the health and wellness of BC First Nations community members. This webinar we will share information about the new lung screening program at BC Cancer and the new Indigenous Talk Tobacco program to support quitting smoking and vaping. I love that vaping's added. BC Cancer Talk Tobacco team members will give an overview of these programs, and how to connect to the team will be made available to answer any questions. At this time, I would like to turn over the meeting to Warren and his team and FNHA. Welcome, everybody. I will move myself to mute. I will watch for hands as we go along. Thank you.
Wonderful. Thank you, Charlene. So maybe just a quick, yes, Charlene introduced me already, and it's our second webinar with the FNHDA. Just a little bit about me. I originally worked for the BC Association of Aboriginal Friendship Centers. I spent 14 years there working for our people moving into cities, much like I did coming to Victoria. We're down in Victoria now for about a quarter century, 25 years, and the Lekwungen peoples unceded in traditional territories, or Songhees and Esquimalt First Nations, as they're known here. I'm originally from the northern part of the province, Gitxsan First Nation through my mother, members of the Gittimax band through her as well. My father's a 3rd generation settler, I guess, as we're calling them nowadays. And I've been at BC Cancer for 4 years, implementing the Indigenous cancer strategy. And part of what we're going to be talking about today is around screening and around lung health. And so we've got our colleagues here with us today. And so very happy to be here to share some information. So with that, maybe I'll just get right into it, and I'll ask our colleagues maybe when they do their part of the presentation, they can maybe give a short introduction as well. Okay, so why are we here today? Well, we are here to talk about lung health, in particular, a couple programs. So the first will be around lung screening programs. We have a brand new lung screening program in BC. But really, this is all attached to the Indigenous cancer strategy. And we gave a webinar, I want to say about 4 to 6 months ago, perhaps now, just a high-level overview of the Indigenous cancer strategy, of which culturally safe screening is one of the priorities. As we know from the very first surveillance study we did for First Nations, cancer incidence is increasing, while rates for other BC residents are either decreasing or plateauing. And so the presentation today will start with a bit of an introduction from my colleague Joanne about our new lung screening program. And then we're going to transition to our colleagues from the Canadian Cancer Society, who will talk about the new program they're implementing with the First Nations Health Authority called Talk Tobacco. And so with that, I will turn it over to Joanne.
Great, thanks, Warren, and thank you everyone for having me here today. Sorry, I'm just trying to figure out how to flip my slide. My name is Joanne Solmonson. I am the program manager for the lung screening program at BC Cancer. I joined BC Cancer and this initiative in the fall of 2020 when we were just kicking off the project. And so I've been here through the project phase, and I'm really excited to see this program through to implementation and to learn about how we can make improvements to the program as we go, how we can reach all of the folks that are eligible for screening. And so that'll be a particular topic of interest of conversation at the end of this seminar, if there's some time for conversation around that. I didn't put it in any of the slides, and I realized that, yeah, I really want to get some feedback as to what we can do to kind of promote outreach to especially some of the outlying communities and more vulnerable communities and whatnot, where it may be difficult to access resources. I have worked in healthcare for about 20 years now, so I am passionate about healthcare. I'm passionate about promoting improvement within healthcare. There are so many opportunities to make services better, to provide better services to the individuals that need them. And so that's really what excited me about this program was I could see that there was a really great opportunity to provide care for this screening initiative, which will hopefully catch lung cancers in their earlier stage and prevent some deaths from lung cancer. So really honored to be a part of this program. I live, work, and play on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people. I'm very grateful for that opportunity. So I'll start with giving a little bit of an overview of BC Cancer. I think that most people will be familiar that BC Cancer does cover the full spectrum of cancer care, from prevention through to screening and diagnosis and treatment. There's obviously a depth of research and education and support around palliative care as well. So where the lung screening program fits in is with the population-based screening programs. And so many of you will have heard of the breast screening or screening mammography programs that are available to women, cervical screening and colon screening, and then of course now the lung screening, which was just introduced. And so this work to develop this program has been underway for a number of years, not starting with that business case in 2018, but actually years prior to that. Our medical director, Dr. Stephen Lamb, has been part of international studies. He has worked to establish a lung pilot study, which was taking place in Vancouver over the last four or 5 years. And that really paved the way for us to do a lot of research and then develop the groundwork for this now provincial program. So while the pilot study was only available in Vancouver and at Vancouver General Hospital, it was very limited, obviously. Not a lot of people can travel from other areas to be able to access that. So we're really pleased that the program was officially launched on May 25th, and we are now receiving phone calls and doing intake for the program. And so I'm excited to share with you more about that. In terms of how lung screening works, we follow a similar pattern to how the other screening programs are operated in BC. And so BC Cancer takes on a lot of the organization around the provincial policies and standards. The promotional strategies are done and managed through BC Cancer. We've got a fabulous promotions team that works very closely with all of the screening programs to promote the programs, to ensure that the information is being shared that's correct, that's digestible for the audience that's receiving the information. And I'm going to share some of the information on the promotions programs and work that they've been doing later on in the slides. But really, BC Cancer is here to kind of establish the oversight for the program, and then we work with the regional health authorities to actually provide the tests that are involved in the screening programs. And so lung screening kind of fits in similar to the other screening programs in that way. And so we as part of developing the program, we had about a year or so of working groups that we had established with representation from across the province, including all of the health authorities. First Nations Health Authority participated in our patient pathway working group, where we designed the pathway that the patient would follow in order to be able to receive lung screening. And so we're very thankful to all of the members from across the province that have participated and helped us to set up this program. So why lung screening is important? It is the most common cause of cancer death in Canada and in the world. And so 70% of all lung cancers are currently diagnosed at an advanced stage when symptoms are already present, and they can be difficult to treat. And I have another slide coming up that kind of shows a graphic of what this looks like exactly. But really what we want to try and do is catch the cancer at the earlier stage when it's more treatable and the survival rates are a lot higher. And so that's how screening works, is we screen people that are asymptomatic, that don't have any symptoms. Sometimes, because our population is a population of people who have smoked for many years, they will have some underlying conditions such as COPD, emphysema, or other things that you may have heard of that are kind of attached to smoking damage. But for the most part, it's a healthy population that we're screening, and we're looking for that cancer that's kind of underlying, that doesn't necessarily show up. And so this graphic here shows you the cancers when they are diagnosed within a screening program. We will find many more stage 1 and 2 cancers, whereas outside of a lung screening program, the majority of the cancers that you're finding are in stage 3 and 4. And that's because when lung cancer presents with symptoms, it is already at that advanced stage. So what's involved in the lung cancer screening is a low dose CT scan of the lungs. And so low dose means that it's about the same amount of radiation that you would receive from the natural environment over about 6 months period of time. So it's really important that we stress that low dose of radiation. It does, is less damaging, and therefore it is safe for ongoing screening, which is what's required, and I'll speak to that in the next slide. So during the scan, patients will lie on a table, and that donut-shaped scanner, you'll be run through that. You have to lay with your arms over your head, take a deep breath, and for about hold it for about 10 seconds, something like that, 5 to 10 seconds. You have to hold your breath on an inhale. And so it's a fairly quick and easy exam to perform. There's no medications required. I don't think that most facilities would require that you would change, as long as you're in loose fitting clothing and no metal. So it's a fairly simple test to perform as well. And so how the CT results work is these images here are actually the images of a lung screen that was done on a patient through the trial program, and it shows the growth of the nodule over time. And so the purpose for doing screening, repeat screening, is, the first screen is to look to see what's going on. Are there any nodules in there? And if there are, how concerning are they? Are they smaller? Are they larger? Some people will have scar tissue inflammation in their lungs as well. So one of the questions that we ask before we send them is if they've had a chest infection requiring antibiotics, such as pneumonia or bronchitis. Even COVID pneumonia can show up as a lot of scar tissue in the lungs, and that can be alarming. So we want to make sure that somebody that's coming in doesn't have any kind of respiratory infections. But what they'll do is they'll keep an eye on these spots that they see over time. And so this screen was done as a baseline scan. The next CT scan was done about 2 years later, and that showed that this small nodule had now grown. And so what they did was they said, okay, let's watch this even closer, come back in 3 months for an early recall CT scan. And when they see that it's grown to a size like this, they can see that that's something that they need to watch and maybe do some testing on. So then in that case, that would be referred for diagnostic workup. And so that's where it gets a little bit more tricky and there's more decision making involved. The good news is that very few patients that go through the lung screening program will ever get to this phase. It's only about 4% of patients that are screened that will have that diagnostic workup. And so really what it is, it's about watching the size and the growth of those nodules over time. And so similar to the breast screening program, it's not a one-time test, but it's something that you'll repeat depending on what the radiologist's recommendations are. And so just talking about who the eligible population is for screening. So as I mentioned, it's for individuals that aren't experiencing any symptoms. Of course, there may be, if somebody's still smoking and they've been a heavy smoker for years, they may have some difficulty breathing and so on. But we want to make sure that the person is healthy and well enough to actually go through screening. And so we do have a health assessment questionnaire that we ask. The individuals are between the age of 55 and 74 years of age, and that's where we see the most lung cancers being diagnosed. And so we really want to hone in on the population that are at the highest risk so that we're not doing unnecessary testing and unnecessary screening. So it's really about finding that, doing fewer screens in order to find more cancers is what we're after here. And so the history of smoking that we're working with is around cigarette tobacco, essentially. And so obviously individuals have other smoking history and whatnot that wasn't related to tobacco, but that's kind of the base of the program, is about a pack a day for 20 years. And so we have a eligibility that we're calculating based on a risk score. We have navigators in our office that are answering phones and completing these risk assessments to determine an individual's eligibility for the program. So the risk assessment involves the use of it's called the PLCO risk calculator. And so it has been validated on an international level through a number of trials. And essentially the risk factors that it takes into place are age, smoking history, education, a family history of lung cancer. So if you have had lung cancer in your immediate family, then you're at higher risk. Or if you've had a cancer diagnosis yourself, ethnicity comes into play as well, and other smoking related health conditions. And so in terms of the ethnicity piece, there has been research that has shown that Indigenous or those with African Canadian descent have a higher likelihood of getting lung cancer with fewer cigarettes smoked, and so they're higher risk within that category, and so it's that's taken into consideration with our risk calculator. So how the lung screening program works is it's a program that you can self-refer to. So most of our advertising that we've done so far really is very high level in terms of the program criteria. We're talking about the fact that we want people between that age group with that 20-year history of smoking. There are a lot of variables that will then decide if they're eligible or not. So it's important that people call in to get screened, and even somebody that maybe hasn't smoked as much, but they have other risk factors at play might still be eligible. Somebody that has smoked more, but is otherwise well and healthy and other things are going well may not be eligible. So it really comes down to that risk calculator that we use to determine eligibility. So as I said, individuals can call into the program themselves to self-refer. They do need to be attached to a primary care provider. So I know that has been a hot topic of conversation in the province over the last couple of weeks especially. And we've certainly come across a few individuals who we're trying to support with attachment, but it is important that that piece is there so that somebody can receive the results and support any kind of follow-up care that might be required, and I'll speak more to that. But essentially, primary care provider can also refer to the program. We have a referral form, there's tear-off slips that they can give to the patient when they're in the office. And so essentially the patient will call us. We will determine the level of risk and complete a health assessment on the individual. And we'll also talk about some smoking cessation support as well. So for individuals that are currently smoking, we will have a conversation with them around what some of the methods are that they've maybe tried to help quit smoking previously. If they've tried, we'll support them by providing resources. And so we're really interested in promoting the Talk Tobacco program that we're going to be learning more about in this presentation as well. And so those are some of the resources that we're sharing, and really about providing a safe space for folks to have a conversation, have a really open conversation about their smoking history. There's no judgment, there's no stigma attached to it. We're really here to help and support in any way that we can, and I'm really proud of the job that the team is doing so far in being able to reach out to individuals and to provide that support. So the navigators have all been trained through a smoking cessation counseling program called TEACH. And they've all also received Indigenous cultural safety training, and so they're coming into it with a little bit of background and that lens as well, which can support some of the conversations that they're having as well. And so what we'll do once we determine that somebody is eligible for the program, we will then initiate a referral for a CT scan to a health authority within the region where they live. I'm going to share with you a map of where the screening sites are located. They will go for their CT scan, and then depending on the findings, we will send the results to the patient as well as to the provider. And depending on what their findings are, they will be asked to return to screening when they're due. So for most people, they will have a normal CT scan. They will be asked to return to screening in 1 to 2 years. Some people will have some incidental findings, and so we'll also be reporting on that. And those are things like coronary artery calcification, emphysema, COPD are some of those kind of lung-related challenges that come up from smoking. And so what we do is we send those results to the primary care provider, and then that provider will have the opportunity to support the ongoing care of that individual. And so that's why that patient attachment is important. And then as well for any kind of abnormal findings, as I mentioned in the slide earlier with the 3 images of the CT scans, you know, if there is a need for an early recall CT scan, then we'll do that. And then if it's something that looks like it's growing really fast, then what we do is we refer that on for a diagnostic workup. So we have a team of respirologists and thoracic surgeons that we have gathered throughout the province that are specialists in lung issues, and they will receive the referral, they will review the patient's case and determine the next best steps. And so in most cases, you know, for any kind of diagnostic workup, there may be a requirement for an individual to travel, especially if they are in a rural area. Not all diagnostic facilities are available, obviously, in some of the smaller communities. So in the north, it would be likely they would need to travel to Prince George, and I believe we have another center set up in Smithers. We're just confirming that right now. But those are very specialized tests, and we want to make sure that that testing is done because it can be dangerous. We want to make sure that that testing is done by, you know, the most reputable surgeons and respirologists in the province. And so we've worked really hard to establish a really high quality program in that regard so that we have fewer risks attached with that. So this just goes over the registration process. There's our 1877 number, as well as healthcare providers can fax a referral to the program. And then what we would do is we would call the client directly. And so we're looking at about 60% of people that will be eligible for the program. So not everybody that calls, as I said, that has that smoking history is necessarily going to be eligible for the program. And so that's why it's really important that we put them through the screening, determine, you know, who are those that are at the highest risk. And then also we have the opportunity to then provide smoking cessation support with really anyone that calls. We're happy to do that as well. We were a little busy out of the gate when we first had the program announced. We didn't have as much time to do that, but now that the dust has settled a little bit, we have a little bit more time to spend with people on the phone around smoking cessation. We've also been spending some time on the phone with people around the physician attachment piece, trying to support them to figure out a way that they can get themselves attached, either through TELUS Health is an option. There are walk-in clinics that people will maybe visit over the years that will be willing to receive results. I know that First Nations Health Authority has a Doctor of the Day program, so we're continuing to have conversations around that if that's something that's being used by an individual, to see if we can tap into that, but more to come on that. And so, you know, we're doing what we can to support individuals that are interested in attachment, because it is obviously it's a very frustrating piece for people. In terms of where scanning is available, these are the various different centers across the province. And so, oh, it looks like my stars might have traveled when we formatted the slide, but there's a pretty good representation across the province here, and so including in the north. And yeah, the stars aren't in the right place. Ignore the stars. Look at the list on the side here, and that will tell you what the centers are where screening is available. And so we'll work with the individual that we're referring to, make sure that we're getting them to the center that's going to work best for them. And then the hope is also that they would receive ongoing screening at that same site. And that's just from a quality perspective. If the individual is screened using the same CT scanner, then those images are going to be easier to compare over time. So that's, you know, that's the hope. It's not absolutely necessary, but that's kind of our goal. And so we will try and refer individuals to the same location year over year. And so, I think I talked a little bit about the smoking cessation piece, that really it is important that we are offering that as a support for individuals that are currently smoking that call in. We find that about half of the people that call into the program are still currently smoking. And so, we do want to try and work with them and support them in their cessation journey. And so, as I said, we will have a conversation with them. We have some resources that we've developed that we'll send out by email or over through the mail. For those that don't have email, we can stick a letter in the mail and send that. There's resources that are available provincially that we tap into and that we just share as a promotion for those resources, so that folks know what's available for them. And sometimes we'll find that people have tried something over the years that didn't work, and then they haven't tried for a while, but they're interested in trying again. And so really it's about encouraging people to keep trying, try something different, maybe that they haven't tried before, take a different angle, talk to their provider about it. And really we want to just provide that support in a safe space as we can. I'm just going to show a video here. I don't know if this link is going to work. Oh, it might. Bear with me.
I can't, the audio is really low.
Sorry, the audio is not coming through.
It's not coming through.
It's not, hey? Okay, let me just try something else then. Just bear with me. I'm just going to pull up the YouTube version and see if that one works a little bit better, okay?
Yeah, I think also when you were sharing, there's the screen, there's a basic, and then there's a tab for advanced. And if you click on the computer audio or video, it might help.
Sorry, what was that?
So when you share your screen.
Yeah. Oh, optimize for video clip. Thank you.
Share sound at the bottom. There's a share sound if you click that too.
Okay.
Might help.
Okay, let me just do that here. Thank you.
The teamwork at its best. Thank you.
Okay. Is that better?
Hi, my name's Shannon. I'm 59
Perfect.
years old.
Yeah, great.
I have 3 children, 2 8-year-old twin granddaughters. I love riding my bike. I love gardening. I like knitting. I started smoking when I was 13. I smoked till I was probably 45. Barbara and I, my best friend, have been friends since our kids were in kindergarten. She unfortunately passed away almost 3 years ago from lung cancer. She never really had any symptoms in her lungs of the lung cancer. And after she passed away, I saw BC lung screening trial, and they were looking for candidates. I went for CT scans, and one of those CT scans showed a small dot on my lung. And then they did another one and noticed that it had grown quite quickly. They knew that something was going on. That day, I was losing my mind, to be honest with you. I was driving, I was hysterical. Talking to my daughter, I was hysterical. In the hospital for 4 days. They removed the cancer, which was the size of a dime. Because of the early detection, In the CT scans, they were able to find it at such an early stage that all that was required is the removing of the cancer. I know it's scary and nobody wants to be told they have cancer, but if it's detected early enough, then the chances are they could do something about it. It's now going to be available in BC to get screened for lung cancer. It's a silent killer, and honestly, it could save your life. It saved mine. Go get screened.
Okay, let me just pull the presentation back up again here. 1 second. Oopsies. Sorry. Can you see my slides again?
Not yet.
Not yet. Sorry. Okay, I've done this wrong here. 1 second. Why is it not showing up? Sorry, I just have a couple more slides and then I'll be done. Am I back?
Perfect.
Okay, good. Thank you. Sorry. So that video is available on our website. I'm going to just quickly show you a few other resources that we've developed that our promotions team has worked really hard on. That we've had also some feedback from patient representative that was sitting on our working groups, and then we've also shared these more broadly with individuals that have been supporting the working groups. And so we have a few brochures that are available in terms of patient education. Just as an overview, there's another brochure that talks about kind of understanding your results and follow-up. There are a number of, there are 2 animated educational videos that are available on the website as well for people to view. And one of the things that we've done to promote the program with providers is created this provider education package that was sent out to all referring primary care providers in the province, and so that is there as a resource. And then of course the website has a lot of information available for all of the screening programs, and so lung fits in there as well. Also, if there are specific information that health professionals are looking for, even just ordering some of the resources that we've talked about, then that's available through the section of the website as well. And then also just wanted to highlight that the work with First Nations Health Authority in terms of community engagement is something that is ongoing, that will continue to be developed in terms of a specific strategy for lung screening. And so that is, I think, the end of my presentation here. So thank you so much for your time.
Charlene here again. Thank you. At this time, did you want to entertain some questions?
I'm happy to do that now, or do you prefer to do it at the end? It's up. It doesn't matter to me.
I think it'd be up to the audience if they would like to have some questions now before they move to the next topic.
We do have a question in chat from Jen. It's, what is the wait time for screening?
Great question, Jen. So right now, and actually I didn't even approach this subject, so not all of the health authorities have started screening yet. So Interior Health has actively been screening since actually the end of April. We've been sending referrals for patients to receive their CT scan. The goal is that when we send the referral, that they would book the patient within 1 month's time. And so it should only be 1 month to receive that CT scan. Now we're just waiting for all of the other health authorities to get up and running. There's been a lot of work that the teams have done around this new software that they're using to read these CT scans, and just a lot of work to kind of fit this program in. And so there is a little bit of a backlog, and some of you may be aware that there are really high wait times for CT scans right now throughout the province. And so it is something that we're working with the health authorities, but the goal of the program is that once you receive your your referral is submitted, that you would be booked within 1 month. So right now it's going to be a little bit tricky in the beginning, as the health authorities are trying to find the capacity for these additional CT scans. They have been provided funding for this, but the actual challenge right now that a lot of the sites that I'm hearing from are dealing with is really just a shortage of techs to be able to do the scan, and a shortage of clerical staff to do the bookings. And so those are some of the challenges that they're working through right now. But once the program is fully implemented and up and running, we do expect that it would be a 1 month wait time for the CT scan.
My question is there on your website, is the referral form there as well?
The referral form is there under that section, health professionals.
Okay,
So yeah.
okay, thank you.
Yeah, we did have a question from Shannon in regards to the referral form and the risk assessment form. So those are both found on the website.
So the risk assessment form is not on the website. That's something that happens in a conversation with the navigator. So it's not something that we've made publicly available. Just because it's kind of a complicated tool in terms of how it works and how it measures the risk and whatnot. And so it's really something that has to be take place through a conversation with the navigator.
Okay.
Yes, sorry, Charlene. She just has 2 follow-up questions. Can nurses do the referral, and what doctor do we fax this to?
So nurse practitioners are able to refer to the program. Anyone can refer to the program. It's a self-referral program. So really anyone can access the program. The piece where the nurse practitioner or doctor comes into play is for that attachment piece. So anyone can refer. You can refer your mom, your sister, your cousin to the program. Anyone can be referred to the program. We'll screen them here at our central program office to determine their eligibility. And we'll just make sure that they're attached to a provider.
Just one quick question. Will your presentation be shared with the participants?
I'm happy to share the presentation. Yes, please go ahead and share it.
Thank you. So do we have any more questions? I'll just scan real quick, see if any hands are up. I think we've covered everything in chat. Thank you. And thank you for entertaining the questions. It's good to get them while they're fresh, especially with a topic that's so heavy and in our world, the reality of our world. So thank you. Thank you, Joanne.
Thank you very much for your time. I appreciate it.
So our next presenter, I'll turn this over to Warren.
Hi, everybody. We are ready for the next presenter on Talk Tobacco.
Hi, I'll just be sharing my screen here. Oh, sorry. Okay, can everyone see that?
We can. If you enable the editing at the top of the PowerPoint, and then if you go to slideshow, You're stopped presenting.
Slideshow. Oh, but I have to be in it first. So.
And then at the top, if you want to be perfect.
It's good.
Yep, it's great. Thank you.
Okay. Hi, everyone. I'd like to say thank you for inviting myself. Oh, why is this going on its own? Thank you for inviting myself and my colleague to present to you today. My name is Kim Moore. So I'm the senior specialist with Talk Tobacco in Manitoba. I joined you today from Winnipeg, Treaty 1 territory, ancestral lands of the Anishinaabe, Cree, and Dakota peoples, the homeland of the Métis Nation. I acknowledge that the water I use is sourced from Shoal Lake First Nation, which is directly impacting Shoal Lake First Nations 39 and 40. So the Canadian Cancer Society respects and honors the difference between traditional and commercial tobacco use. They acknowledge that certain communities have a distinct and sacred relationship with traditional tobacco. We work with communities to understand their needs and to recognize how life's lessons can impact a person's journey. And our quick coaches use a strength-based approach to support the person's quick journey. Just to provide you with a program overview, Talk Tobacco is a partnership between the Canadian Cancer Society and Ontario Health's Cancer Care Ontario Indigenous Cancer Care Unit. In 2017, a group led by the Indigenous Cancer Care Unit called the JOAC, which is the Joint Ontario Indigenous Cancer Care Committee, indicated the need for tailored and culturally appropriate cessation services and recommended CCS lead the development of a program to meet their needs. So in 2018, CCS conducted a survey of Indigenous healthcare providers and smokers to determine feasibility of the services. They also did a literature review of Indigenous specific tobacco cessation quitline services, and funding was secured from the Canadian Partnership Against Cancer, CPAC, to create culturally appropriate cessation services for First Nations, Inuit, and Métis peoples. And just to provide you with a program implementation timeline. So in 2020, we launched our telephone cessation support across Ontario, Saskatchewan, and Manitoba. And we also launched our website, our Talk Tobacco website. In 2021, we launched our Talk Tobacco live chat and text support in Ontario, Saskatchewan, and Manitoba. And then in 2022, this year, we launched the partnership with the MNO, Métis Nation of Ontario, to develop training for their frontline teams to have cessation conversations and to provide relevant referrals to cessation support. And we also launched our Talk Tobacco services in British Columbia in partnership with the First Nations Health Authority. I'll now turn it over to my colleague, Victoria, and she'll be doing a couple of slides here.
Good morning, everyone. Kisakikit Hukakflik Napikaak. My name is Victoria Stevens, and I am originally from the Dinaha Nation. I am hailing you this morning from the unceded territory of the Silk people located in Penticton, British Columbia.
So I joined Canadian Cancer Society in February. I was interested in the position that they identified as the quick coach and promotions expert or specialist, talk tobacco. So I'm just going to talk a little bit about the engagement strategy, and you'll have to forgive me because I am new. So I just come on, I'm starting to learn more about the programs and services. So Talk Tobacco, they wanted to ensure that the engagement strategy was relevant and accessible, that it was a relevant and accessible program for Indigenous communities with respect to Indigenous health and wellness. They I don't know, they engaged in a number of strategies or meetings in the different provinces. So Ontario, Saskatchewan, Manitoba. They met with different leaders. They, just met with them to find out what was necessary if we were going to go with this program. What were the needs that the communities identified needed to happen in the program? So they wanted to speak with some of the healthcare providers, just trying to find out what's important for if we're going to offer this, what are the things that they thought were most relevant. And then from those engagement sessions, so there was a number of them that were that were engaged in over the year or so. They did focus groups. And from that, they shared back to the committee, I believe it was the JOA committee that they shared their findings back to, and then began to tailor the training that needed to happen with, because Canadian Cancer Society has a smokers helpline, they have operated that successfully for a number of years. They looked at sort of what were the key successes of those programs and how they could then tailor that to meet the needs also of what they were hearing from these engagement sessions. So next slide, please. Some of the findings that they had, they decided that the quick coach needed to be well educated in Indigenous cultures. And in the case of sort of my role, I am originally from BC, so I'm familiar with sort of the lay of the land and what kinds of challenges that some of our communities might be facing. So that's kind of what they were looking for, and that's some of the feedback that they received at some of these engagement sessions. They highlighted that the relationship was really important, that they needed to have a relationship established with non-judgment and easily approachable. Next bullet, please. They decided that the one to a couple calls just wasn't supportive enough for the people they were talking to. They said that it may require several calls. Sometimes it's a challenge to connect with people. And then even when you're talking with people on the phones, you need to be able to establish that rapport with them and to be able to provide that safety for them. So that was highlighted. And to be able to, it says here that, to be able to understand the importance or the significance of how family and community play an important role in an individual's life as well. So that was highlighted. Youth vaping came out as a significant issue, one that is facing many of our communities, because the attraction to vaping as a less harmful avenue to smoking is definitely showing up in many of the communities. So that was a significant issue. They talked a little bit about how mental health and addiction play a significant role in people's lives, and that the quick coaches needed to have a good understanding of what impact that would have. And so being able to understand that, there wasn't just, and I guess for me, it's more taking a holistic look at individuals and saying that, it's not just the one area that you can focus on, that smoking cessation. You do need to be able to be aware that there are other impactors impacting why a person might smoke. And so quit coaches needed to be familiar and understand that finding. So the cessation services, here we have just, people are able to call in to speak to a quit coach. And so I will say that I haven't had a chance to meet all of the quit coaches, but I've met a couple of them. And all of the quit coaches that I've met, they're very easily approachable. They're very understanding in terms of some of the challenges that First Nations, Indigenous people have survived over the years. And, Joanne, she mentioned the TEACH program. That was one of the things that I was required to attend as soon as I was hired, was the TEACH program. And they do a section on motivational interviewing. And Canadian Cancer Society also had me enroll in a workshop for motivational interviewing. And I will say that from my own experience, those are some of the things, those are some of the strengths that are coming out of this program that I see, because myself, I've, provided counseling with our people for many, many years. And just there's a slight difference when you're doing the motivational interviewing. And the thing that I really like about it is that when they say that it's strengths-based, it really is strengths-based. And it really is about focusing in on what you're hearing from the client, and to really be engaging yourself to listen to what are those things that you could pull out to give back to the client that the client is actually saying themselves. Like they're talking about what the successes are, or they're talking about what the challenges are, being able to pull that out and to turn that into a strength, right? And to show them, or just to prompt them in terms of, how can we get this to go from A to B and to make it a little bit more positive, or to build that a little stronger kind of thing. So I really appreciated the training in that sense. So of course, now here I am, I'm talking on a tangent, sorry. We have our phone line, we have our live chat. All of these you can connect with the quit coaches. We have tech support. We have our online community support through Facebook and Talk Tobacco. There's a quick map. In that quick map, we're able to, and I haven't checked some of the remote communities, but you're able to kind of look at what some of the programs and services are that might help you in your quit journey. And then they have a quick calculator in terms of, the cost of cigarettes and how that might impact sort of your day-to-day living and whatever. So next slide, please. These are the posters and postcards. I do want to go back to the logo just because I missed that in my presentation in terms of the engagement. So the logo, when you look at the Talk Tobacco logo, it's that thought cloud. I did see some of the engagement findings where they had gone back and, this was the logo that the people came up with, and there was a consensus around that they appreciated this logo the best. And so I really just wanted to say that, yes. And there was even some engagement in some of the youth sessions. The youth, they kind of liked maybe just a little bit of different colors, but basically overall, this is the logo that they chose. So I really have to highlight that because I thought it was interesting. I'm reading how the engagements went for that. So here you have the posters and then postcards. So you're able to contact me and I can send you out posters as well as postcards that you could just give out to people. And yeah, next slide, please. Next slide, please. Thank you. Oh, I guess she's pointing to tell me that I need to say that you can also download these online. Sorry, Kim, can you do next slide, please?
I'm trying and it's not advancing.
Oh, okay. Good to know.
Oh, here we go.
Okay, here you go. So one of the things that we found is that like this is our referral pad, and just like Joanne had talked about, there's this tearaway piece that you could give the client when they're leaving. It just gathers some general information, and then that gets sent into our office. And it has been reported that 60% of those contacted by the Quick Coach really would not have bothered to call, because we actually do a proactive call where we call them and start that conversation about their quick journey. Anyone can make a referral and encourage their clients to contact Talk Tobacco. Yeah, so next slide. I think that's it for me. So I think, let's see, next page. Yep, that's it for me. Thank you. Thanks for your patience, all my relations.
Thank you, Victoria, and I apologize. It had a mind of its own and was advancing beforehand and everything else. So my apologies on that. So in terms of some of the supports, we just wanted to give you a picture of what, if you were going to go to our website, which is www.talktobacco.ca. You'll get to this page here, and we provide information about the program, overview of the services, and frequently asked questions. And there's a section for healthcare providers and information and incentives. Our social media, through the engagement, we learned that Facebook was very popular. So we have this Facebook page for Talk Tobacco, and we post 2 to 3 times a week. And we also did a paid Facebook ad campaigns and have resulted in an increase in website visits to the website during the campaign period. So for client overview, from July 2020 to February 2022, First Nations was the most commonly self-disclosed identity, followed by Métis and Inuit. People called Talk Tobacco seeking help and information about quitting, requesting general information and materials, and wanting help and information about staying quit. And Talk Tobacco clients reported using cigarettes more than e-cigarettes and vaping products. And the nicotine patch and cold turkey were the most cited quit methods. We also found that women were most likely to call Talk Tobacco, and the highest contacts were men and women between the ages of 35 and 64. Current and former Talk Tobacco users most frequently reported smoking 11 to 20 cigarettes per day, and were most likely to be rated by the Quick Coach as being in the action and early preparation stages of change. Health benefits / concerns and children were the most common reasons for quitting. And referrals were most frequently made by Quick Coaches, CMHC Stop Study, and the Ottawa Model for Smoking Cessation. We had 164 clients from April 2020 to February 2022. 752 client contacts. 37 clients reduced their cigarette use, and 32 clients quit completely. And 14 clients had already quit, but they called to be able to maintain their resolve. So our text and live chat, which from September 2021 to February 2022, we had 28 subscribers to the text program and 57 live chats. So this is one of our clients that we had, and he so graciously allowed us to be able to share his picture and some of his quotes. And so his quote is, "Their support was marvelous, and with their help, I've been able to be smoke-free since January 2020. It's given me more hope. I can now take a breath of fresh air or a bit of food and truly appreciate it." And if you wanted to know more about his story, you can probably go online, and in the same magazine, he was featured in the February art magazine. And so to conclude, I just wanted to provide you with all our contact information. So we have our phone number, toll-free phone number, and then the website, French and English. We have our Facebook link. Oops. Sorry. A Facebook link and a link to our service provider newsletter. We also have a 15 and 30-second promotional videos on YouTube, and the links are there, and then Victoria's contact information. Thank you. Thank you for your time. And if there's any questions, then we can try to answer those.
Hi, Charlene here. I'll just quickly scan. See if there are any hands up before we go to the question. There was one question we'll backtrack on, and this was from Jen Nelson. What is the wait time for the screening?
I think we answered that one earlier, Charlene.
Okay, I'm just double checking, do my backtrack. I do have a question. I love the concept of the quick coach. Definitely going to promote that. Victoria, amazing job doing your very first presenting. You're very calm. You got the information out. I appreciate that. The question around screening, who can do the screenings if somebody calls the toll-free number, for example? Would the quick coach just refer them to somebody, or can they help support the screening process?
I guess I will answer that. There is no screening for talk tobacco. Anybody can make a referral. So if it's like an elder or somebody working like a diabetes educator or somebody in the medical field, anyone can make that. Even the person themselves can make a self-referral. And once that referral is made, they will be contacted within 3 days. 1 to 3 days, they will be contacted by a quick coach. Because what we found with the Smokers Helpline is that 60% of people involved with the Smokers Helpline were referred, which I think kind of indicates the fact that sometimes it's easier to for somebody to make that call to you as opposed to you reaching out sometimes.
Thank you. I'll just scan again to see if there are any hands up for any further questions. So I see we have no more questions. I've been taking feverishly notes. Thank you. Thank you. I'd like to thank the health directors and FNHA staff and FNHD board for this opportunity to support this webinar. And as a board member, I was more than happy to support this and learn more about the screening process. I feel that more screening opportunities to reach early detection is going to be work in our favor at the long-term goal. The concern around men's health definitely having this screening opportunity, because men's health is and probably will continue to be the toughest one to get the message out. How do we entice the men to come? Having the opportunity of texting toll-free numbers to keep it private so they can gather information will help them make that decision. So thank you, BC Cancer Agency, for thinking outside the box and reaching that hard population. I'd just like to recap what I heard. Talking tobacco for 4 years, Warren, working within the BC Cancer Agency. I feel the strength that you brought out and with your team has really heard the voices of the general public to how can we get this information out? How can we target all the populations, be it from those that use technology to a toll-free number? So thank you. Thank you for taking on this job and working, especially during a world pandemic. The last 2.5 years have been difficult, and you guys done an amazing job. Joanne, 20 years in the healthcare system. So you have a real capture on how to reach the population. And that is amazing. That is amazing. I will pause here because I recognize Victoria's hands up. Victoria?
Charlene, thank you so much for your kind words. And my apologies for interrupting. I guess, you know, I was so nervous I forgot that there were a few things that I wanted to ask. So I have started to attend the meetings with the regional tobacco leads at First Nations Health Authority. I attend those bi-weekly meetings with the team and Asta Murray, and I'm really feeling quite supported in terms of our journey forward. We did launch the Talk Tobacco program at the beginning of April, and I know that, you know, on the First Nations Health Authority, there was, you know, information shared about Talk Tobacco. One of the things that I would like to pose back to the health directors is how can we support you in promotions of the program? And so the way that you could get in touch with me is, you know, I think Kim kind of showed my email, but it's victoria.stevens@cancer.ca. If you want to send me an email, that would be great. But I am part of my job, so I'm going to be a quit coach for a couple of days a week. And then the other part of my job is to actually get out into the communities and to be promoting Talk Tobacco. And so this summer, my manager has encouraged me to try to see what events are out there so that I can start getting out and handing out. We have some fantastic gum. I've actually chewed a couple of packages of gum in my work hours, but we have some promotional packages of gum that sort of promote the program. We have our postcards, our posters. So I will try to get out into community this summer just to really promote that. So just back to you, how can I support you in the promotion of the program? And then also, how do we encourage more referrals in the province or in the program? So those are the questions that I would like to leave the directors. And again, I shared my email, so please get in touch with me and let me know how we can support. Because I will say that, you know, I'll share my little story. My mom has been a smoker for many years, and I told her I was taking this job, and she's 75 years old, and she's like, oh darn. She said, now I think I'm gonna have to quit my smoking. And she said, if you've got any good tips, then I expect you to share them with me, because my mom has struggled over the years, you know, with her own journey, and she talks a little bit about the challenges that she has, and that it really is addicting, and she's not able to quit. You know, sometimes she'll be able to reduce her, you know, use and things like that, but she has never ever actually got a long period of quitting. I, of course, have been very respectful of my mother because she is my mother, and so I'm not going to be knocking on her door or calling her up and saying, well, did you quit today or anything like that? So I will be respectful in that sense. But I do recognize that it is a big challenge, you know, and it's something that we need to address. And I really appreciated BC Cancer and their messages because, you know, our health is so important. My mom is always telling me, if you don't have your health, you know, and my grandmother used to say this as well, if you don't have your health, then you don't have a lot, right? So I know that many of us in our communities, we address our health, our well-being, our belongings. You know, there are, you know, ceremonies and things that we do to attend to ourselves. So I'll close with that. All my relations. Thank you.
Thank you. And thank you for asking that question. How do we reach the health centers? Definitely webinars is a good place to start to reach out to the health directors. I would recommend connecting with community health reps or support staff. Respecting each nation may have a different title for their staff. Friendship centers, homeless shelters are another avenue that we can fax this information to advertise your numbers and to promote any of your activities. Reach out to the health centers with the support of First Nations Health Authority and First Nations Health Director Association to get mailing addresses. You might want to mail out products so that we can use it in our health fairs or our newsletters or the pamphlets we give out door to door. Some ideas to how we can do this, and community engagement. We can definitely, I'm looking at pulling in some resources together to do aftercare program. How do we move forward with an aftercare program? We have, so I definitely will keep you guys on my radar and invite you to setting up an aftercare program for here in the Northwest in the Terrace area. So I hope this was able to answer some of your questions. Early detection is key, is definitely the message I did hear from your presentation. Rather concerning around the stage 3 and 4 cancer, around that's kind of scary for me, but that's our reality, correct? And explaining the low dose radiation was definitely helpful. A lot of people are fearful to what they are being exposed to, and putting it in the concept of a low dose, as you know, I would even go as far as comparing how much tobacco you're having to a low dose of radiation. But you know, weigh that out. That's just a mama bear in me though. I love the idea that it's 3 months once something's detected. There's 3 months rescanning. I like that. Is another what I heard. Looking at the history and the family history, smoking, the age of the person definitely helps us narrow down the population we would like to target in doing these referral forms. I love the idea of the referral forms we can support the nurses. The nurses do get a lot put on their plate, and us having the opportunity to support that is amazing. The one question that's kind of worrisome for myself is a GP. We do have a lot of people who don't have a GP, so definitely how can we bridge that gap? The question around the wait time for the screening is 1 month. I did make a note of that, so that is promising. Long screening programs is lung screening programs, and the toll-free number that I jotted that down. Definitely will promote that on our website, in our newsletters, and we will click on thank you for sharing your websites. We definitely can use that tool, www.bccancer.bc.ca/screening/health screening referral forms. Definitely is going to be very helpful. Getting us on your email list would definitely be another avenue that we can share with our staff, so our staff can get on board to start accessing your website. The big step around adding the quit smoking coach. Victoria, the work you do is critical in my eyes. You're the link to get people into the door with BC Cancer Agency, and most specifically with our older population, having that calmness. That's why I made a point. But when you presented this work, that calmness that you bring is going to put them at ease, that misjudging that is off to the side, and having that buy-in and understanding the importance of screening and why and who should be. That was an amazing step, BC Cancer Agency. Thank you for having those quit smoking coaches help you draw the people in and lower the barriers to accessing the screening. These are the things that I heard during your presentation. Again, thank you for sharing your email address and the opportunity for texting, and the toll-free numbers and the Facebook page is definitely another way of reaching our population. It was an honor to sit here and hear your presentation, and to play my small piece in supporting the work moving forward around screening and cancers. As we all know, that early detection is key. Removing barriers is key. And what I've seen from Warren, from your team, is that you're hitting all the markers and addressing the barriers. And I'd like to say thank you. Thank you. My hands go up to you and your team. I truly appreciate this. Coming from a long history, I have my mom's side of the family. There's 15 members. Out of the 15 members of my mom's brothers and sisters and her mom and dad, 13 of them died of cancer, or one form of cancer or another. And so it's definitely in our communities and in our world. And having somebody listen to what the barriers are, this validates that BC Cancer is listening. And for that, I'm grateful. Thank you. Thank you. I will just now quickly move to the chat here. And health is wealth. Thank you, Warren. Yes, health is wealth. And Susan, thank you for sharing the ladies' emails. And Joanne.
And I just want to share one last thing, if I can, because something that I've been really moved by over the last couple of weeks since I've been talking to some of the people that are interested in registering for the program is that the people that are either still currently smoking or previously smoked are extremely humble and very thankful that this program is available to them. There's this sense of, I've done this bad thing, therefore I'm not deserving of care, or I'm not deserving of your extra attention. And so it's really moving to be able to talk to people and say, you do matter, your health is important. Yes, you have an addiction, which is not your fault. It's really, I think that this population of individuals has been so stigmatized and blamed for their health issues that it's really, it's just really powerful to see this kind of come around in a way where folks can be supported and not blamed for their actions, and that they can hopefully be supported throughout and get to the point where they do feel that they have the strength to take their health in their own hands more, to take that opportunity to explore smoking cessation. But even without that, even if they do continue to smoke and continue to use tobacco products, their health matters, and that's something that a lot of people, it's really resonating. It's starting to resonate with people, and it's heartening to see that. So I'm just really happy to be part of that and to share that message that everyone's important.
So I have some bragging rights here in Kitsimkalem. Our elders, none of them smoke. We have over 100 employees that work for Kitson-Kalem organization. Out of the 100, 3 smoke. So our numbers are low. And I was just shocked. I was shocked. I've worked in the interior, Aboriginal organizations, non-Aboriginal organizations, and it was kind of like 60-40 that smoke and 70-30 that smoke. So when I took this job here 9 years ago, and I started, like, the first thing I need to do, population gaps and services. Well, what are the populations? What is heart disease and chronic illness, and go on, right? We, as a health director, we look at the statistical numbers. So when I got to the smoking part, I'm like, hey, this is amazing. This is bragging rights, people. This is bragging rights. So we do have low numbers. Thank God, of cancers in our community. But sending the message, I'll end on this note, sending the message that still lung disease, lung cancer cause 60% higher when you're smoking cigarettes is definitely a message that has been heard loud and clear. And thank you for reminding us of that. And I would like to thank everybody for joining today's webinar. And I look forward to receiving the email so I can share it with my staff. And continue the good work. Stay safe out there, and blessings to each and every one of you. I would like to turn it over to, I'm just going to double check my notes here with FNHA if they had some comments they'd like to add. Thank you.
Yeah, hi folks. Just aware of the time here. I just wanted to say thank you. I see Karen is I know we're at 12:03, so I just wanted to say thanks, folks. And the presentation was wonderful. Yeah,